Is Claire McEvoy, who's dietitian and senior lecturer at the Centre for Public Health in Queen's in Belfast, who's going to speak to us on brain diabetes feasibility trial evaluation of a brain health intervention among older adults with type 2 diabetes living in rural Ireland. So welcome, Claire.
So thank you very much. And yes, I can confirm that I am Claire McEvoy from Queen's. And I also confirm that I am only one of many people, a big team of people actually, part of the brain diabetes team, and very multidisciplinary. It's also a cross-border collaboration. So we're part of the Cross-Border Healthcare Intervention Trials in Ireland network. And I'm going to talk to you about our experience of developing, well, it was adapting really a proven intervention for our population and focusing on brain health. But obviously we were struck by the COVID-19 pandemic as well. So I'll talk a little bit about our experience of that too. So see, how do we work this? Okay. So for those of you who aren't familiar with the FINGER study, this is our inspiration basically for brain diabetes. So FINGER is and was really the first large multi-center randomized controlled trial that tested a multi-domain intervention for brain health, and it was conducted in Finland. They recruited just under 1,300 older adults who were cognitively healthy, but at increased risk of dementia. And they were randomized into receiving this multi-domain intervention or just into a control group. They received standard healthy lifestyle advice. So the multi-domain intervention consisted of several components. So there was an active diet that was based on the Finnish dietary guidelines, a physical exercise component that combined aerobic resistance and also balance exercises. There was a computer cognitive training component for cognitive stimulation, and also vascular and metabolic monitoring. And so these were delivered by healthcare professionals, so it was quite, resource intensive, and using individual and also group sessions. And it was the trial was over a period of 2 years. So just to highlight some of the findings then, we have the control group in the blue line and the intervention in the red line. And for the first time, this FINGER study showed that we can actually slow down cognitive decline using a lifestyle intervention. So small but significant impacts on the primary outcome, which was global cognition, but also in some of the domains of cognition as well, including executive functioning, which is thinking and planning functioning, information processing speed, and also complex memory tasks. So all in favour of the intervention compared to the control. But you can see that the separation between the groups was really only happening from 12 months onwards. So also there were some broader improvements in terms of functional benefits for patients in the intervention arm, and also better health-related quality of life. So that was our sort of inspiration, and there are a number of trials that are ongoing around the world in 30 different countries, more than 30 countries now. And brain diabetes is one of these multi-domain FINGER intervention trials. So we're all testing sort of different adaptations of the FINGER model in different populations, in different settings. And what we really want to know is, can these results be replicated in other populations? Because, the intervention was so intensive that it's difficult to know that question. What are the necessary and optimal doses that we need to include in these multi-domain interventions? And can they be delivered, importantly, using low cost and scalable approaches? So that leads us to brain diabetes. And out of all of the multi-domain trials that are happening around the world, we're focusing exclusively on people with type 2 diabetes. We know that type 2 diabetes is an established risk factor for dementia in later life. It's also a big public health problem. So more than 250,000 people are living with type 2 diabetes in Ireland, probably likely to be a lot more because there's 1 in 10 cases of undiagnosed in people over 50 years. And we know the prevalence is also increasing. Also, from the broader literature, we know that type 2 diabetes is associated with about 2 to 4 times increased dementia risk. And we're also focusing on rural communities because potentially they might be more likely to experience greater inequalities in accessing diabetic care compared to those in urban areas. So brain diabetes was delivered in 2 phases. So the first phase was way back in 2019, and really what we wanted to do there was think about ways we could adapt the finger and multi-domain model for our target population. So it involved a combination of literature review, but also that qualitative engagement with the target population. So we did focus group research with a cohort in Sligo and also in Enniskillen. We published the paper, so I'm not going to go through all of the findings of that, but I'm going to highlight some of the barriers to adopting diet, exercise, and cognitive training behaviours, because obviously behaviour change is challenging, it's very difficult, and we need to maybe think about ways and we can support people to do that. So some of the barriers in our population, these were older adults with type 2 diabetes. So some of the barriers to adopting a brain healthy diet was living alone and eating alone. So I'm not going to read out all the quotes, but here's one. I'm on my own, my husband's dead. By the time you cook something, you just have no interest in it, but it's just getting the portions right. Also, there were well, for almost everyone, they brought up the barrier of cost for healthy food components like olive oil, fish, and berries. There were also strong contextual, cultural and social factors that were sort of influencing food choices, and that might be difficult to change for some people. So things like the social function of food. So this was all about, there was discussion about, indulgent sweet foods like cakes and pastries and biscuits served with tea when you go to visit somebody in an Irish home, and it's really rude to say no even if you are diabetic. So that was brought up as an issue, and there is a quote there: I might go into a house and I might be offered a cup of tea and a slice of tart. It's bad manners to refuse, but I wouldn't buy that tart in a shop. Also, farming is the backbone of our rural Irish community. So it was discussed quite a bit about how certain foods that would be perceived as brain unhealthy, like butter, cheese, and red meat, do hold a cultural place and would be difficult to give up completely. So in terms of exercise then, when we asked about the exercise programme, there were a few barriers, including beliefs about exercise, perceived self-efficacy to do the exercise programme, and also more external factors like accessibility of the exercise programme. So in terms of beliefs about exercise then, a lot of our participants preferred walking as an exercise and felt that they got enough exercise and physical activity in that way. Others, particularly men who were sort of farming land or performing manual jobs beyond retirement age, felt that they got enough physical activity through their occupational activity. So there's a quote there: I think you get plenty of exercise around the farm. I wouldn't be interested at all. When I get home at night from milking cows, I like to sit down. Also then, some of the comorbidities that are associated with type 2 diabetes, like poor vision and circulation, were perceived as barriers towards engaging in an exercise programme. And external barriers like where the class was being held, the location, how far it was away from their house, do they have to drive? Do they have to drive in the dark? Where is there parking facilities? And the timing of the classes, all of those were raised as potential barriers that we would have to think about because they could influence someone's engagement with the programme. So the other aspect I wanted really to ask about is this computerized cognitive training program that was unique for the finger model. And there were some barriers to potential engagement with that, including accessibility, self-efficacy, and self-motivation. So accessibility was really around broadband access. And again, there's a quote there: "Where I live is in the midst of the country and we get no broadband at all. When we looked into it, we were told the only way to get it was to move home." So that's fairly telling. And again, self-efficacy was really around those diabetes-related complications, like poor vision, and people were talking about using things like magnifying glasses really to work on computers. And also, there was limited skills and I suppose IT knowledge and competency in this group of participants. And some were actually just not even interested to learn new computer technology. So I wouldn't be into computers anyway, no interest at all. My daughter does all of that for me. So these are all of the things that we had to kind of think about and trying to adapt the program to increase the acceptability for our target population. So we retained all of the major components. In terms of what we decided upon was that we would base our dietary advice around the MIND dietary pattern, which is at the time was based on the latest evidence from the diet and dementia field, but it was quite a good, easy, adaptable model for people with type 2 diabetes. And also then we tailored that to population food preferences and really focused on balance rather than restriction. Physical activity, we wanted really to have a flexible approach here to encourage. We did want to have the combination of aerobic, resistance, and balance exercises, but delivered in a very flexible manner. So we did have the supervised group exercise classes, and it was based on the XWell. It's a commercial exercise program. Some of you may have heard of that already. It's in Ireland. It's there's a lot of good evidence behind it for high engagement, particularly amongst older adults, and especially it's been especially designed for people with chronic diseases as well. So it's really perfect for this population group. We also developed home-based exercises as well. So having that flexible approach, walking was also promoted as part of the exercise component. And then we decided on a platform called Brain HQ, which is a cognitive stimulation online. I suppose it's a combination of auditory and visual games that have been shown to train areas of the brain like attention, learning, processing speed, and memory. And it has got quite a good evidence base behind it. And also it's been used in some of the other worldwide finger network trials. So we decided that that's what we would do. And also internet access was required. So we had to actually build that into the inclusion criteria for the trial. And then we would be promoting cardiometabolic monitoring by our study nurses at each of the planned study visits, which were at 4, 6, and 12 months. So this was going to be a 12-month feasibility study. And we developed also a suite of resources to promote and support behaviour change around those different components, particularly the diet and exercise. Okay, so phase 2 then is when we were just preparing to get started with recruitment in, I think it was May 2020. And of course, COVID struck. So we had to pull together as a team and decide what are we going to do here. So it was clear we couldn't deliver some of the intervention components the way that we wanted to. So we had to adapt to deliver them safely. So the study design then is a parallel group randomized controlled trial. We wanted to recruit 140 people who were 50 years and above, who were within 5 years of a diagnosis of type 2 diabetes, and they were cognitively healthy. And they'd be randomized into the multi-domain intervention or the control group. And our study sites were in Sligo and in Fermanagh. So in terms of COVID, then we had to change all of our, so we were delivering our intervention components, diet, exercise, cognitive training, using individual and group-based face-to-face sessions. So all of those had to be changed to remote sessions, and they were delivered only at the individual level. So we had to drop all of the group-based support for that we had planned for the project. Our face-to-face outcome assessments were continued to be conducted by the study nurse, either in the participant's own home or in a dedicated research centre using, we had COVID sort of risk assessment and guidelines in place to allow that to happen safely and to minimise any risk for our staff and also for the participants. And all of this took a lot of time to then get through ethics again. So we really had only a very smaller amount of time to recruit our study participants. So we had to actually abandon our 12-month follow-up, and it became a 6-month feasibility study. It was a feasibility study anyway, but in terms of our main outcomes, what we were interested in was about, can we recruit these people? Can we retain them into the study? Can they change their behaviours to the desired behaviours that we want them to do? And then we also had secondary endpoints where we were collecting some clinical and cognitive data. So in terms of recruitment, we planned 18 months for recruitment. We only had 7 months to recruit. We managed to recruit 79 eligible adults. 2/3 were recruited at the Sligo site. And they were randomised into either the intervention or the control arm. 28 completed the intervention and 36 completed the control. Now, we as a group had set a lot of success criteria to measure our feasibility, which tells us if we can scale this up or not. And we feel that we definitely met our feasibility criteria, although we didn't meet our target recruitment. There was a reason for that. Our window of recruitment was much reduced, but our recruitment rate of 6 to 7 participants per month was actually greater than what we set out to achieve initially. The retention rate overall was 81%, which was greater than what we had set out at aim at least 75%. And then we had also less than 20% retention difference between the intervention and the control groups, which also met that particular feasibility target. Some of the reasons for withdrawal, so we had 15 withdrawals from the trial at various stages, and some of the reasons were lack of time, illness, COVID as well, change in personal circumstances, and there was only one person that actually withdrew from the intervention group because it was perceived as burdensome. So that was quite good. So our groups were also well balanced at baseline. So this was a population of people who were in their 60s, mostly male, 68% male, clinically obese, relatively good metabolic control in terms of HbA1c. They were cognitively healthy on the MMSE, which is the mini mental state examination screener. And actually, the Mind Diet score was 8.1 mean, so that indicates sort of moderate adherence to the Mind Diet. Step count was quite high as well. So I'm not sure if this is truly representative of our type 2 diabetic population. They seem to be pretty, a healthy bunch. What we were interested in is, what was the compliance with some of these, all the sessions that we had offered as part of the intervention. And this summarises the compliance with those different components. So the highest compliance was with the cardiometabolic monitoring, unsurprisingly, because that was delivered at the study visits with the nurse. And then about 80% completed in fact, all of the dietary sessions with the nutritionist. All of the participants completed their baseline exercise prescription, and then about 80% completed 50% or more of the exercise review appointments. And with the cognitive training, a larger proportion of our intervention participants completed less than 50% of the anticipated sessions that they should have been completing at home. And in fact, only out of that proportion of participants, they maybe logged on once or twice during the whole programme. So then we wanted to see, does this actually change dietary and exercise behaviours? So we looked at the MIND diet, and there was significant shifts towards a brain healthy diet in response to the intervention. So after 3 months, we've got the intervention in blue and the control in orange. So after 4 months, there was 3-point increase on average in the intervention group, significantly different from the control group. And that was actually maintained at 6 months as well. And that was greater than our target that we had set for 2 points. In terms of exercise, we just looked at daily step count. Again, the intervention group did increase on average until about 10,000 steps a day. There wasn't any between group difference in step count. Nevertheless, it is promising. I mean, they started off pretty high anyway. And also about 85% completed a minimum of 2 of the home exercise sessions. In terms of cognitive performance, so we didn't actually see any difference between the intervention and the control groups in change in cognitive performance at any of the time points, 4 or 6 months. So no change in global cognitive performance or in domains of memory or executive functioning. We weren't really powered to detect changes in clinical measurements at 6 months, but we did actually see trends for metabolic improvements in response to the intervention. So greater reductions in BMI, in HbA1c, significantly greater improvements in triglycerides. And also when we looked at the SF-36, the quality of life questionnaire, we did see improvements in both the physical and mental domains scores of that in the intervention group, which tend to worsen in the control group. Okay, and we also carried out some interviews with our study participants to see, how they found, what was their experience of the study. And we did find that it, amongst those who did complete, and there's a quote there, "My health has improved greatly, my diabetes has improved, my sugar levels have decreased, and it has made improvements to my life." So they did highly rate their experience of taking part in the study, and they said that they would recommend the programme to friends or family members with type 2 diabetes. The support provided by the nutritionist and the exercise instructor were very helpful to motivate and sustain that behaviour change. And that was supported also by the written educational materials, which people found really helpful. Some participants did say that they would have preferred more peer support, which we weren't able to offer. And the main, I suppose, what came out very clearly in the focus groups is about the computer cognitive training. So tedious, I have to say, tedious is the one word I would describe it as. It was not training my brain so much as training my peripheral vision. So didn't really enjoy that element. So in summary then, despite COVID-19 and all the challenges that we had, brain diabetes did prove feasible in terms of recruitment and retention of older adults with type 2 diabetes living in those selected rural areas. People were able to make the MIND diet and exercise changes easier than the computerized cognitive training. There was a positive appraisal of the intervention despite the remote delivery and the lack of social support. And of course, we did have to cut short the follow-up time. So that's a major limitation of this feasibility study. So it's difficult to know if it would have potential efficacy, really. So we didn't see any difference, as we suspected, in cognitive performance, but we did see small, promising indicative effects on metabolic health and quality of life, which are important in that cohort. And going forward, we just, as a team, need to think about some of the refinements that we need to make to optimize the delivery, particularly for cognitive stimulation. So I just want to finish by thanking all of the brain diabetes team, our other collaborators, particularly in the XWELL program, our PPI members, all of our funders, and they're all listed here. Too many to mention, also in the audience today as well. So thank you.
Thanks, Claire, for that. Any questions from the audience? Just maybe, just while the mic is going down, just one interesting thing that Some of you will know Professor Sir, as he now is, Chris Whitty, who's the Chief Medical Officer for England. You'll have seen pictures of him during the whole COVID thing, but he gave a talk in the last week based on NHS England demographics, and they have a very, very comprehensive demographic trends thing because of the way the NHS is structured. But one of the things that he has pointed out as a very serious risk is that the young populations, the cities are becoming places for young populations, and older people are moving out of cities in the UK in huge numbers to the country, to areas that we would regard now as the catchment area of Model 3 hospitals. So that's going to have an enormous impact on our workload in the future, and I suppose it plays into the group that you're talking about. Does the mic reach the back?
It's
There was
here.
a hand. There was a hand.
Here.
Oh, you have?
Yeah.
Okay, go ahead, please.
Hi, thanks so much, Claire. And I suppose just as a comment, really, you know, we were part of this study in Sligo, and I think it's fantastic that in a smaller, you know, rural area that you can kind of engage in a big kind of cross-border randomized controlled trial. And that the cross-border health intervention trials network was exactly for that, because people have better outcomes if they have access to trials. We had lots of nightmares. I'm sitting beside Orla, nurse here. COVID and, you know, changing everything online, and the broadband was an absolute bleeping disaster. But at the same time, you know, it's really positive to see, despite our shorter period, we actually, you know, got pretty good recruitment on this side of the border as well, which is fantastic. So I'm just so excited to see it presented here today. It's fantastic. And, you know, it is feasible, and we do have to look after our older people in rural areas, and they're going to have to sort the broadband out. But the exercise and the diet piece is really, really important too. So thanks a million.
Thanks for that. Any other questions? Anna, the predictable. Oh, yeah, sorry, there's a question in the back, yeah.
Yeah, thank you, Claire. I really enjoyed the presentation. I was just wondering, so what's next? I mean, these results are very promising. In terms, like, I know the numbers are small, but like they kept going with it. They seem to benefit from it. There's an indication that this is something that will really work in the real world. So, is there plans for, the future?
Definitely. I think this also gave us the opportunity, as Jared just said, about how we work together and collaborate together. And I think I didn't mention that, but that was something that is a great outcome of this study as well. So it's how we sort of leverage that, build upon it, and then look for the next step. So we do need to think as a team what refinements we make to the actual program. Do we need to have small pilot tests of things again? And I'm really thinking about the cognitive stimulation here. And maybe there's some things that we can learn from some of the other worldwide finger trials that are ongoing elsewhere. So for instance, there's one in Korea that's using paper and pen exercises for cognitive stimulation that might work better for our population. So perhaps we do need to do a few more little pilot tests with, if we do make some amendments, but I think we would really like to scale this up and, you know, look for other recruitment sites as well. And so we're going to meet up and discuss that as a team, see how we move forward.
Actually,
and
you
then,
answered my question.
Yeah, okay. Just behind you, Aidan.
Yeah, the time commitment, it struck me looking at that this is going to take about 2.5 hours a week for people. That strikes me as a big barrier. I haven't seen 50 for decades, but you know, 50-year-olds are busy people. 2.5 hours a week is a huge commitment. I just wonder, is there a brain light diet that is less time intensive?
Well, arguably, I mean, I think with COVID, so that was the pre-COVID protocol. And I guess because we had to change to remote delivery and we had to adapt, that it's made things even probably potentially more resource heavy, less time commitment for people to engage and travel to meet people, you know, and to have the individual and group sessions. And it still showed feasibility in terms of changing behaviour. So I think we might try and maximize that model, which is a legacy from COVID, to move to more remote delivery for behaviour change interventions as well, which might actually help fit better in busy people's lives and help try and support behaviour change in that degree. But yeah, I think that was probably one of the aspects that we wanted to look at anyway, in terms of trying to maximize engagement by looking at the time commitment that would be involved in all of these things. So we did actually reduce it from the original finger protocol, and then it has been reduced again for the remote delivery. So,
any final questions from the room? Just maybe within the whole, I mean, the finger interventions, or a suite of interventions, is there any evidence that one is any more effective than the rest, or how much of it do you think is a sort of Hawthorne effect, where if you focus on an individual and their health, and you kind of target it, you can expect some element of improvement?
I think from the dementia research, evidence-based, it seems that we do have to address multiple risk factors, and that involves multiple lifestyle behaviour changes if we're going to have an impact on disease process. So it seems that maybe the exercise works in a different pathway from the diet. So some of the process evaluation from fingers showed that diet had a particular beneficial effect on the executive functioning. And there's some evidence to suggest that exercise actually promotes neurogenesis. So there might be different pathways that some of these behaviours focus in on. And actually there's a longer term follow-up now for finger, where they're following up people for the next 7 years to see if they can look at the impact of the finger intervention on Alzheimer's disease and other dementia outcomes.
Okay, fascinating. Okay, thanks very much.